While PAs and NPs often do very similar work, we are different professions and we don't always know things about the other profession. So, one of the things we're going to talk about today is an area of medicine that some people think that PAs are not allowed to work in. We're talking about neonatology, working in the NICU. I was recently told by a nurse practitioner, and let me be clear, I don't think that she meant any malice or had any ill feelings towards PAs, but her experience as a neonatal nurse practitioner led her to believe that PAs were not able to work in that specialty. And after she said that, I was really kind of confused. And I thought, well, that doesn't seem right because I think PAs work in pretty much any area of medicine. So I did a little digging and I found a neonatal physician assistant or physician associate now who has been working in the specialty for many years and who's actually doing a doctoral project on PAs and NPs in neonatal medicine. So she's going to talk a little bit about that training difference and how PAs and NPs come to work in the specialty. She's also going to tell us a little bit about the specialty, what makes it a great specialty, the pros and cons, the schedule, the pay, all of those typical things that we talk about. Hi, it's Michelle with the Medicine Couch. If you like what I do and you want to help support the channel, please hit that subscribe button down below. Hit the like button if you like this video and leave me a comment. I love to hear what you have to say about the video, what your experiences are, if they're the same or different, or what you think about the information that I presented. Now let's hear about working in the NICU.
Hi, my name is Theresa Bromley. I go by Theresa. I am a senior neonatal physician assistant, and I've been practicing in pediatrics for 20 years and specifically in neonatology for 15 years.
Okay, so you have lots of experience with the small humans. Has your whole career been in pediatrics or neonatology, or did you start off in something else first?
I initially thought I was going to be a surgical PA, and then I was wrong. I have been specialized in pediatrics since I graduated.
So I wanted to dive in first before we start talking about the specialty. I don't understand the terminology. I've never been around the specialty at all. So do people call it neonatology, neonatal medicine, or do people just refer to it as the NICU, or is the NICU just part of neonatal medicine?
So neonatology is the science of babies, right? So whenever we're talking in a medical realm, neonatology is what is used. The department is Department of Pediatrics under neonatology. So, but in general, I usually say newborn intensive care or neonatal intensive care. More people understand that terminology.
That kind of leads into what exactly the patient population is. Is it determined by like age? Or are you talking about, preemies and then up to a certain age, or is it more determined by the severity of the condition that the newborn has?
So by definition, a NICU, a baby, is a newborn baby that has specific needs outside of a regular newborn nursery. There are different levels. I work at the level 4, which takes all gestational age babies born down to 23 weeks. Usually we'll attend 22 weeks because when you're in the 22 to 23 week gestational age range, there's a big difference in one day. So we go to those deliveries. We also take care of any baby that has a surgical issue, congenital heart issue, has any need for respiratory support, any kind of structural anomaly that does not allow them to do the 3 main things babies are supposed to do. They're supposed to be able to breathe and oxygenate on their own. They should be able to regulate their temperature on their own, and they should be able to feed themselves to maintain hydration and sugar levels. So that's the kind of patients that we get. We will get patients that were born in our facility. Since we're level 4, we get transfers in all the time. And we keep those babies until they are ready to do all those 3 things I just mentioned.
Can you run through kind of those levels?
Level 1 is your general nursery. Baby's born, you don't have to do anything for the baby. A level 2 is called special care, and what ends up happening is those kids need a little bit of help. They need to be monitored to make sure that they don't have any signs of infection. Maybe they need to have antibiotics for a short course while we're making sure that mom's not sick. Maybe these babies have low sugars. If they have to have bilirubins checked and they have to have bili lights for their jaundice, that can be a level 2. Everything else after that is a level 3. So level 3s kind of vary. There's like all these little numbers and letters behind it that have kind of gone to the wayside, but it's a wide range. So any baby has any kind of respiratory support that they require long term. If they have anything that they need prolonged antibiotics, concerns like that, they'll go to level 3. Preterm babies can go to level 3. In general, level 3s will keep babies down to 30 weeks or so, but that's kind of a soft number. I used to work in a high level 3 that we kept all of our babies, and we didn't send anybody out unless they needed surgical support, or if they needed subspecialty support that we didn't have. Level 4 takes care of everything. We have to have all of the personnel, imaging, diagnostic facilities for any kind of baby. We have to have surgical support, 24-hour surgical support, 24-hour subspecialty support. And the level 4 specifically has the ability to do extracorporeal oxygenation with ECMO, which in general terms is your heart-lung bypass. So our facility does that now.
If you are a PA or an NP working in neonatology, are you usually just working in like levels 3 and 4?
Usually level 1s, level 2s, you don't really need one of us. They sometimes will have one of us for emergency availability for deliveries that they didn't expect to be bad. But pediatricians take care of those. You'll see neonatal nurse practitioners in level 2s. Now, I say it this way because the field of physician support in newborn intensive care has traditionally been taken care of by the nurse practitioners. Nurse practitioners have to have at least 2 years of bedside experience, and then they go into a specialty program, and then they get clinical teaching specific to newborn population, and so that's usually who it is. For us, we're called neonatal advanced practice providers in some realms. Most realms are going towards that terminology. We're seen in level 3s and level 4s because there's such a high need, and those kinds of NICUs are turning into team-based. So it kind of extends the reach of the physicians to have us there.
So what is the path for PAs to work in neonatology? How do we qualify to work in that setting?
Today, the way that you can become a neonatal PA is you can go to a fellowship. And most of the fellowships are anywhere between 12 months, 18 months. They're also called residencies. So basically a postgraduate program. And they focus specifically on the procedures, the medical background required to practice in neonatology. In general, clinical thinking, if you are able to clinically think, you just need the background. So the fellowships do that. Flip side of that, there are only, I think I found 10 neonatal fellowships that include PAs, and there's more of them coming up because the need is so great. Outside of those, you can be lucky and find some place that needs someone, is willing to train you. That is where there's inconsistencies. This is why some people say, oh, PAs can't work in NICU. You have to find the right place. So if you're like a new graduate and you want to do NICU and you can't get into a fellowship, that's okay. You can find any place that is willing to train you. And I would suggest that you go to a high level 3 or level 4. When I transitioned from hospital-based pediatrics into specifically neonatology, I was lucky enough to find a small community hospital with a great team of neonatologists, and they took me under their wing and really trained me the way they would train their fellows. So I was very lucky. And people who come into our program is very lucky because they get an extensive training with me and my colleagues. So that's basically how you can go in right now.
I think that's a good lesson, and I've heard this in almost every interview I do. If you have a real heart or love for a particular area, a particular specialty, there is usually always a way. It just is harder, and you have to persevere, and you have to be, a real kind of go-getter. You have to go find those opportunities and probably be willing to locate to wherever you find that opportunity, because it is more difficult than just a regular going into cardiology or something like that.
Yeah, I mean, the reason I went into becoming a physician assistant, now a physician associate, was because of the diversity, the ability to go back and forth.
Can you tell me a little bit about kind of the special things that you're dealing with or seeing in neonatology?
If you're going to work in critical care, if you're that kind of person who just really likes the process of figuring out what's wrong and fixing it in a collaborative setting, you can't do it by yourself. I think that NICU is one of the best because we have much greater good outcomes. It's not a depressing setting. We have children that come in, they get sick. It's very satisfying to help them out and see them grow. We have kids that stay for like 5 months and all of a sudden they're okay, they get to go home. That's one of the best things about being in NICU. Other things that I like about it is very procedure based. I do chest tubes, I do umbilical lines, I do central lines. We're pretty much the go-to team when it comes to needing to do a procedure. You have different realms that you work in, and different levels of autonomy. So when I'm in the delivery room, I'm fully autonomous. I'm the person that's getting that baby through and stabilizing that kid and bringing him or her up so that we can continue managing the baby. And then in the actual NICU, with the sicker kids, we round with all of the doctors. We're the point person for communication, both at the bedside, to the attendings, to the fellows, to the consultations. So it's very well-rounded position. When we go up to the well baby nursery, in case there's a baby that's sick up there, again, very autonomous. I can go upstairs and say, I don't like the way this baby looks. I'm bringing the baby down. Or kid's okay. Let's wait. I'll come back up in 20 minutes. It's very satisfying because it touches a lot of things that we don't get to do in any one setting.
It really kind of actually surprised me when you said that one of the great things about working in neonatology is that you have so many good outcomes. I guess medicine has evolved so much, Dave, that these kids really have a good chance, and so as a whole, more kids are making it than not, is what you're saying?
Yes. I mean, like the age of viability right now is 23 weeks. There's a lot of good that we could do. Yes, that do I get depressed when I lose a baby I've been working with? Yes, that's absolutely true. Um, but is it different than being in the hospital setting and I lost a patient? No. Do I have it happen a lot? No. Most of the time, babies are very resilient. And if you take good care of them and know when to do something and know when to just let them do their thing, we do well.
One thing I was going to ask when we were talking about, PAs and NPs working in neonatology, do you have any idea, and it's okay if you don't, but do you have any idea of like how many nurse practitioners are neonatology nurse practitioners versus how many PAs roughly are working in neonatology?
No.
No.
I
Okay.
mean, I can say that there's enough of us that there's a buzz about what to do with PAs and neonatology. I also can tell you that um, the every year a survey goes out about the neonatal nurse practitioner population, and it's low. It's been low since 2014. I'm hoping that that changes, and I'm hoping that there's more PAs that go into neonatology because of medical advances, the population need has completely outpaced the amount of neonatologists that come out now. So we need more team players. We need more clinical thinkers at the bedside for these kids.
What does a day kind of look like for a neonatology PA or NP? Like how many patients are you seeing, and what kind of things are you doing on a regular basis?
So a lot of that is dependent on the type of unit you work on. So I'll talk about what I'm doing now. So right now, we have a almost 60 bedded unit. Nurse practitioners and PAs neonatal PAs can work a variety of different types of shifts. Generally, it's a 12-hour shift, or some places do a 24-hour shift. The daytime looks like you come in, you get your sign out about your babies, you get your sign out about what type of potential issues there are in the delivery room, such as expected deliveries that may go bad, expected admissions from those deliveries. And they can range anything from a congenital heart anomaly or something that came out on newborn testing and the baby would come. So these are the things we talk about, and takes about 30 minutes for us to go through all the babies unless we have a really sick one. In general, I carry between 7 to 15. 15 is a bad day. In general, it's like usually around 10 babies, 7 to 10 babies that I take care of by like my babies. They would be mine. I'm the first contact provider for those babies. There are 3 of us on the team, and we take care of a third of the unit in terms of direct patient care. After you get your sign out, you pre-round on your kids, see your kids, and then we get together with a fellow and a neonatologist. We go over the x-rays with a radiologist downstairs, and then we start rounding on those babies with our nurses as a team. So everybody, even though I have my personal babies, I can give my input about other kids on the team. So the 3 of us together really truly work as a team. Like if somebody needs help with a procedure, and hasn't been able to do it, one of us will come in and try to help out with that too. If the fellow can't do something, we come, and if we can't do something, the fellow comes. So it's very collaborative. And while we're rounding, we are always in charge of any deliveries that come that need us. And there's a lot. There's a lot. A normal day would be anywhere between 7 to 10 deliveries that we attend during a 12-hour shift. And we try to have the person who's not actively rounding or about to round on the patient go down to the delivery room as we keep going. So that's a daytime. And then once we're done rounding, we take care of calls, talking to patients' parents, any procedures that needs to be done, and respond to any emergencies on the unit, off the unit, in the ED, in the delivery room. So that's daytime. Nighttime different. Nighttime we're very autonomous. At night, the team, it's still us, one attending, one fellow, but sometimes the fellow has to go on transport. Our fellows cover both our level 4 and a level 3 down the street. Our attending at night does the same. They also cover transports. So at night, it's us. We take care of our babies. We take care of each other's babies. We take care of anything the residents' babies need. We round with the nurses at night so that everybody's on the same page. And then we kind of just ride the night, see what happens, go to deliveries, bring in babies, all of that. The nighttime can be very busy. On a bad night, we can bring in 4 or 5 admissions. So we have to do all those things. But again, team, me and my 2 fellow providers, we make it happen. That's what we do. So that's a level 4.
So you talked about your procedures. What are your favorite procedures to do?
Oh, my favorite procedures are PICC lines. So anybody who doesn't know what a PICC line is, it's a percutaneously inserted central catheter. So basically a really long IV, a really tiny hole. Those are usually my favorite ones. They're very satisfying to do. They're technically challenging.
What are some of the other procedures that are often done in the NICU?
You have to know how to intubate. You need to be able to do arterial draws, putting in peripheral arterial lines. Some people can do that, some people don't. The PICC lines, like I said, umbilical lines, we put for immediate access at birth. We're lucky because we have the umbilical cord available, so we can put central lines in through the artery and the vein in order to provide sustenance and also to provide central blood pressure monitoring and blood draws. Lumbar punctures, urinary catheterizations. We place the nasoduodenal gavage tubes in. What else do we do? We do a lot.
Do you guys run codes?
Yes,
Yeah.
because a lot of we're on the floor, right? So we have our office centrally located on the acute side of the unit. So anything happens, we're running over there. So yes, we are often running a code until a fellow comes or until an attending comes, because that is what we do, right? We are the support person.
What kind of things, if any, have been a surprise to you in working in neonatology?
The amount of autonomy has been a pleasant surprise, but I do like the idea that I have this level of autonomy, but I'm still in a team.
Yeah.
There's a lot of comfort in that.
Mm-hmm.
The ability to figure out what's wrong with someone who doesn't tell you how they feel is a definite surprise. I never thought that I could look at a kid and say, I think this is what's wrong with that baby without hearing anything. That was one of the bigger surprises.
What are the big things that you would advise people if they're considering this specialty? What are the downsides? What are some of the negatives that you would tell them to think about?
I think that one of the downsides to what we do is that no matter how much experience you get, you're not the final say. That can be hard. So if you don't have that kind of personality, then I suggest not going into this kind of field. And also, if you're not a self-studier, then you should not come into this field. Like I said, there's a wide range of the kind of education you can get prior to. I'm hoping to change that. But you have to be able to say, I need to know how to do this, and either ask for help or find it yourself. And the hours, it may sound nice to have 3 12-hour shifts, right? But if you are working at high intensity, 3 12-hour shifts in a week, and you have a family and you want to be able to be there, you have to understand that it's not a guaranteed. There's many instances where I end up working 62 hours a week, my colleagues too, just because we have a hole and somebody has to be there. So it's just, that's what you have to think about.
Yeah, and like with any hospital positions, it doesn't matter holidays, weekends, none of that matters. It's you still have to be there.
That is correct. I'd say if you want to do this, you should be flexible.
Just in general, to give people an idea, as a PA or an NP working in neonatology, can you either give me a salary range that you think people should expect, or can you kind of equate it to other specialties and where it falls in the scale?
In general, it's on the high end. I would say that we're more in the 60, 80 percentile.
Okay.
And again, it's very dependent on the region.
Do you have any idea if any of the fellowships or residencies, are they only looking for new grads?
They're not. They're looking for anybody who's interested and has the kind of personality that could work into this.
Anything else that you would advise people who are, looking to transition from one specialty into NICU?
So if you're interested in neonatology, a good source is Neo Reviews. It's through the American Academy of Pediatrics. The Neo Reviews is a journal, and they give you information of what's going on. They give you the opportunity to earn CMEs, and they do questions. It's a really good resource.
So you are actually getting your doctoral degree right now, correct? And I understand that your doctoral project has to do with neonatology. Can you tell us a little bit about that?
Yes, what I've done is I looked through, found research about how neonatal PAs came about, the background, the shortage on bedside providers, about how nurse practitioners become neonatal providers, about routes available for physician assistants to become neonatal providers. And also part of my project is I am developing a online program with the intention of it being a neonatal boot camp so that anybody who's interested in going into neonatology will have the just the background information that would be helpful to get you started.
Well, that sounds like a great project. Be sure to let us know when you get that boot camp done, and we can feature it and let people know when it's available.
Thank you.
Yeah. And if people haven't gone to school yet and they're looking and they know that they want to go into neonatology and they have the option, is there a recommendation one way or the other whether you think they should go PA or NP, or is it really just whatever is best for the person because the opportunities will be there either way?
There's a couple things. I mean, if you know for sure you want to go into neonatology and only neonatology, then you should be a nurse practitioner. Honestly, I mean, you go and you get your degree in RN and you have to practice at the bedside, so you're making money while you're getting that qualification. You go to nurse practitioner school and you're working with the population that you adore. Can't, and it's a direct route. That's like the best thing. It's a direct route. You
Right.
know how to get there. There's a ladder. So yeah, that's what I would say. If you're not sure, and this is the reason I went to be a PA, you know, if you're not sure what you want to do and you want to take your time figuring that out, you can be BA. If you wanted to be, if you have NICU on your list of things you want to do, you can go PA school that has available to it a NICU rotation.
So if somebody is in PA school or has already been accepted to a program and they find out that they don't have any kind of NICU rotations, do you think it's possible for the students to work, through their school or another school to line up NICU rotations?
I'm not sure. Part of the problem with trying to secure a rotation in a place that isn't affiliated with your school is there's a lot of legalities involved and contracts involved, so they may not allow that. But it's worth asking, hey, we have this affiliation with this hospital. They have a NICU, but we don't have a NICU rotation. Can we arrange for it?
Yeah.
Yeah, sure.
Yeah,
Yeah,
never hurts to ask, right?
sure.
Yeah.
If you want what you want, go for it.
Okay.
Ask the question.
Anything else that you want to say about neonatology or a pitch for why people should go into this specialty?
I think that if you're really interested in being a team player, having a good amount of autonomy in a safe environment, in a rewarding patient population, that NICU can be for you. There's really not many subspecialties or specialties that you can say that you enjoy working with your patient. You can do so much for them and you have the support always available to you. So those are the reasons why I think that this is a good specialty.
Well, thank you so much, Theresa, for sharing your knowledge and for setting the record straight on who can work in neonatology and how you get there. So thanks for joining us.
Thank you.
It does sound like a great specialty, but if you're still looking for the specialty that speaks to you or just curious about what other PAs and NPs are doing in medicine, you can watch these videos here and also go to the playlists on my main channel page. As always, thanks for joining me. Take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.